Welcome back. This is the part that I think you're really going to love. For those of you who are physician leaders, nursing leaders, anybody who's an aspiring leader, this is the part of the program that is really probably of most interest to you personally. The rest of it's important for the program, but this is the piece that's going to be really important for you as a leader or an aspiring leader. And so the importance of leadership is never underestimated, I think, in any program. I think that everybody recognizes that each program has to have a leader. And so it comes as no surprise that one of the core elements of a robotics program and of any program is you have to have some type of some person or some type of leadership structure that'll enable the program to move in a direction that needs to move in. And so the thing you have to remember, though, is there's a ton of books out there, and there's nothing out there I can replace in terms of leadership. There's all kinds of books on things about the characteristics of a leader, the types of things that leaders can do, the types of skill sets leaders must have. And so I'm not going to repeat all of that stuff, and I understand things like emotional intelligence is important and having sensitivity to your stakeholders and all of that stuff. There's nothing here that I can say that isn't going to get to the point of repeating any of that type of stuff. So I wanted to put something in this program that was a little bit different, that really got to specifically in this type of program, what are the aspects of leadership that are going to be expected of you? And so the thing about this is, remember, when you become a leader of a robotics program, everybody starts looking at you. And what there are is stakeholder groups. And these stakeholder groups are all going to be looking to you. And what's interesting about the stakeholder groups is each of them is going to have a slightly different perspective of what they expect of you. And so what I wanted to do in this program is to focus on those expectations, things that I personally found that happened to me when I started to develop as a leader, but also things I observed that other leaders were having in terms of expectations that they must meet. So I wanted to put it into one place in one part of the program, and this is, I think, the best place for it. Obviously, if you want books on leadership, there's tons of them out there, and I think I've read more than my fair share of them. But I wanted to specifically focus on a robotics program and the expectations of the stakeholders group on you as a leader. So who are those stakeholders, and who are they, and what do they want? Well, the main I've got 5 of them here. But it's physicians, administration, nursing, community, robotics committee membership. And then I put a little bit of a sub-bullet on robotics committee membership to talk about succession planning. So I've got a couple slides on that because I think that's important too. Because as a leader, you are going to be expected to play a role in succession planning. The least amount of role is you give up your position and somebody else gets put in that place. The more, I think, more progressive way of doing it, though, is to anticipate when you're going to leave or if you're going to leave and start grooming people for it. And so we'll go into a succession planning as well. But physicians are a unique group, and they're going to want to know things about you that are important to them, things that they value. That's going to be true of every single one of these stakeholder groups. So administration is going to have certain values, and they're going to have certain expectations. Nursing, certain values, certain expectations, etc. And so I wanted you to get a piece of this before you go diving into a robotics program, because the day one, the minute you start a program, people start having expectations. And what happened to me one time is, years ago, we started a program at a hospital I was working at, and I remember everybody kept saying, "Why do we need a program? This is dumb. This is a waste of time," and stuff like that. Within the first 30 days, I completely understood why you have to have a program, why there needs to be leadership on that program. I remember walking down the hall and realizing there was a point where I could never walk down this one particular hall. It was really close to the operating room, and I couldn't walk down that hall without somebody stopping me and asking me a question or coming to me with a complaint or a concern or something about the program. Not necessarily about why we had the program, but something within the program that they thought they needed to bring to my attention. And so in the past, I'd say, well, who did you complain to before I got here? And then I was working with another guy at the time in a co-lead type of situation. And I never forget, they said, well, we never knew who to go to. Meaning they've been having the problems all along. They didn't know who they can go to. So that's the first thing you realize, is that all of these people have expectations. And right now, if you don't have a program, they don't know who to go to. The minute you start a program and you become the leader of that program, guess what? They paint a big red X on your back, and you are the person. You're the one that they're going to go to with all of these types of things. So get ready for it. I think it's It's kind of intimidating when you very first start it, but it's kind of cool after a while because you start getting good at it. You start taking care of problems. You start resolving things. You begin to realize that there have been problems there all along that people have been concerned about, but nobody's been doing anything. And you start becoming that person who does something about it. And you can develop their respect and you develop the credibility with the people at your institution. And so that's the trip you're about to take if you're going down this path. If you've been down before, you know what I'm talking about. If you've never been down before, I'm going to tell you, it's kind of scary at first, but it's awesome because once you get through it, you become a person who knows how to do this. And that's like the cool part about it. So hang on, and I'm going to talk to you about each of these groups' expectations. So physicians, regardless of title, they are physicians first. And how I think I've always known this, but how I learned this was when I became a chief medical officer. And then when I moved over, I was working over corporate. And I was presenting to a group of chief medical officers, and I had we were talking about a specific contract and supply chain, and we were looking for their approval. We wanted them to sign on and endorse this particular deal because we knew it was going to be somewhat contentious with some physicians. And so we wanted to make sure the CMOs were on board with this. And so, but I thought, they understood it. They've all worked in administrative positions. They understand the importance of this type of deal. So I thought for sure I had their buy-in, and I didn't. We got to a point of a vote, and the vote got turned down. It was not approved, and so it was a real eye-opener for me because I thought it was going to be unanimous in approval. And I walked out of the meeting, and I had a colleague of mine came up to me afterwards, and he stopped in my office, and he said, he goes, "You want to talk about what happened?" And I said, "Yeah. I mean, I'm a little upset." I go, "I can't believe." I go, "I've been working with these guys for years. Why would they do that?" And he said, "Terry, you got to remember, they're physicians first. You started out by talking to them as if they were administrators." And he goes, "And it just got off on a bad footing, and everybody had to retreat back into their physician cloak, so to speak. And once they did, they couldn't get out of it. They couldn't think, how would I do this? Not necessarily as a administrator, but how would I think of this as a physician?" And so they had a lot of concerns, and I was the concerns were things that I had personally resolved in my head, and I thought that they would just trust me to say, "Hey, don't worry about it. I've looked into this. I think we're going to be on safe ground here." They wanted to know. They were really kind of concerned, and you'll see as we go through some of the things that physicians in general value, you'll begin to understand why they were having some hesitancy about sort of sliding through this one too quickly. I didn't treat them like physicians first. I had to approach them that way. And so it's amazing. It doesn't matter if you're a chief medical officer or a VP of health affairs or whatever. If you're a physician first. And so what do physicians value? Well, they value what's right for patient care. It always comes back to that. There's always going to be somebody in the audience who says, "But what about the patient?" And as long as the patient's taken care of, they're willing to move on down the stream and start looking at other things. But that's number one. It's primum non nocere, first do no harm. They want to make sure we're not going to be hurting people. They also value the scientific method. Most physicians have had a pretty vigorous training in the scientific method. And so they have an enormous amount of value in the science, and they have an enormous amount of value in the literature. And so it's not uncommon for somebody to say, "What does the literature say? Do we have any data on this? Is there anything out there that tells us that this might be a better thing or a worse thing for our patients?" And it's not enough to get up there and say, "There is no literature." You really have to get up there and say, "I've looked into this. This is what I could find." And even if it's like a small amount of commentary or something like that from another group who's experienced a similar situation, they want to know that. They want to know that somebody else has been looking into this, and that more importantly, the person that's presenting to them has looked into this as well. So in order to have credibility, you have to have that ability to get up there and say, "We looked into this. We found whatever, or we looked at another organization and they did this, and this is what their outcomes were." And people feel a lot more comfortable with it as long as there's a method behind it, particularly the scientific method. So literature plays a big role with physicians. Quality and patient safety is obviously of utmost importance. Primum non nocere, I know I said that before, but it's worth repeating. Translates into as first do no harm. And so physicians want to know if we're going to do anything, if we're going to change anything, is this going to impact our quality? Is this going to impact any patient safety issues? Because if it is, we want to know up front that it's the right thing to do. And a lot of times, if they don't get that sense that somebody is looking out for the patient or for the patient's safety, they're really, really reluctant to jump on board with anything. So same is true in robotics. If you're trying to do something new or you want to try a new procedure, someone's going to say, look, has this been looked into before? And what's the evidence out there for it? So you have to be aware of that as a leader. You have to realize that physicians are going to move in that direction and be ready for them. Next one is autonomy and independence. No doubt about it. I mean, physicians are an incredibly autonomous group and value their independence. And over time, as you start to see more and more physicians going on board as employees, they have to give up some of their autonomy. But it's amazing how, despite that, they maintain a lot of times they maintain their independence and want to maintain their autonomy. It's not something that's given up lightly, so you have to value that as well. Have physicians giving input into processes, going to them and saying, hey, listen, you're a problem solver. Help me solve this problem is a lot better way than going in and saying, well, we've decided for you, this is the way it's going to be. It usually doesn't win a lot of friends and doesn't influence people very effectively. So I've found it's a whole lot easier just to go in with the problem and say, this is the problem, you help me solve it, or you help us solve it. And you get a lot more buy-in from that. And not only that, not only they have a feeling like they've been able to influence the process, but it allows them to maintain that sense of autonomy and independence, and that is that they were able to have a vote on this, so to speak. The relationship with nursing, physicians work and train side by side with nurses from the beginning. And you have to remember that over time they develop that relationship. And every once in a while you hear about a physician who complains about a nurse or a nurse complains about a physician. Those are really outliers. As a general rule, physicians and nurses get along exceptionally well, and they have a relationship, and that relationship is tied to that patient and what's happening with that patient in terms of their care, and especially their outcome. And you have to remember that tight relationship is important. The physicians always want to make sure the nurses are on board with something, and the nurses always want to make sure the physicians are on board with something. They don't want anything to disrupt that relationship because it's such an important part of what they value. And then last, which is really tied to this relationship with nursing, which is specificity. A lot of times we forget, nurses are out there. Nurses, you'll see under nursing, it'll say sensitivity. Nurses are the sensitive group for us, meaning, and I mean this a little bit more than what you're probably thinking. I mean it in the sense that they're out there sort of looking at things, looking at patients, looking at vital signs, and trying to detect any abnormalities. And when they do, any slight abnormality, contacting a physician and making them aware. Physicians, on the other side, have to do something different. That is, not every time somebody has a low-grade fever or somebody has, a heart rate that's slightly elevated, not every time are they getting sick. It could be related to something completely different. And physicians have to be the ones who have to go, wait a second, I think this is just related to their surgery. It's not an issue right now. I'm not that concerned about it, meaning they have to be more specific in their diagnosis, so to speak, that this is not a problem. Or they have to be more specific in their diagnosis that I do think you're onto something. You've triggered an observation for me that has alerted me to this idea that there's a problem with the patient. And so that working relationship where nurses come with high sensitivity and physicians come with high specificity is the thing that I think really sort of binds them together, but also makes that working relationship so successful. Nurses alert us to things that are happening out there. Physicians are the ones who have to act on it and make definitive choices about types of treatments and diagnoses and things like that. So I think that that's just something to sort of keep in the back of your mind when you're working with physicians and nurses out there. Remember, like I said, always lead with what they value. And when I go talk to a group of physicians now, I usually start with something on this list. I usually start with, this is what I did a study, or I participated in a study, or I'm aware of a study that just came out, or I think this is going to help with patient safety, or this is a quality improvement project, or this is something that we're going to do that's going to enable our nurses to be more powerful in their positions and help you become better at what you're doing. Anytime you can relate it to something that they value, they're more likely to listen to you. And then you can start talking about things like cost and utilization and, even the Joint Commission at that point. Once you've won them over that you're in their camp, they'll listen to the rest of the things you have to say. So administration, expectations will vary. And to me, this was an eye-opener. I had moved over corporate, and I had gone around and met with a number of leaders. And I asked them really two questions. And I said, what are your expectations of me? And what does success look like for me 1 year from now, based on what your expectations are? And everybody gave pretty much the same answer. They were real similar. We want you to, act with courage, and we want you to get more influential with physicians, and we want to reduce costs. And they really sort of had almost like a list of, I would say, almost generic kind of expectations. And the next thing I did, though, was I said, okay, what does that mean to you? Tell me what that means. And that's when things started getting a little wobbly. And what I found is that everybody, despite the fact that they might be using the same language, they don't mean it exactly the same. And they have differing ideas about influencing physicians, and different ideas about be more courageous, and different influence about cost reduction. Some people are looking at cost reduction and saying, help us in this particular area. Other people are thinking, no, we want you to work in this other area. And it's just amazing to me how, because of that, it creates a lot of conflict, because you can have two leaders telling you the exact same thing, but they mean different things by it. And a year later, in one of their eyes, you look like a failure, in the other one, you're a rock star success. And so you have to be careful of that. And so I found out really the hard way, and that is approach them a little bit differently. It's okay to ask those questions, and when they give you this vague kind of answer, to be ready with a counter answer, so to speak, and that is define success for them. A lot of times they won't. Most people aren't walking around with these definitions in their head when they say things like, I want you to be more influential. What does that mean? They really don't always take it to that next step and say, what this means is A, B, and C, or X, Y, and Z. It's something different for everybody. So if you can tie them down to that, and they're willing to give you that, that's great. But that's a very, very small percentage of people out there who can do that. Oh, the other thing to remember is I kind of pick on administration with this one. This was the exact same thing with physician leaders as well. So it's kind of interesting. It didn't really matter if they were administrators or physician leaders, but it was those in leadership positions, and the ones that I'd been talking to were primarily in administration. So it was like I said, it was a real eye opener for me. But what I mean by define success for them is if they get vague, let's say they say, be more influential with the robotics, surgeons performing robotic surgery. Say, I hear what you're saying, and how about if we define a little bit better? Let me make a suggestion. I've been looking at our data, and I think there's a lot of opportunity in our data. And I think we can get a 5% improvement in utilization, specifically OR turnaround time. I think we can get a 5% improvement in complications related to, robotic prostatectomy, robotic hysterectomy, and robotic colorectal surgery. And I think we can get an improvement, 5% improvement in cost for supply expense for those three procedures. If 1 year from now, this program was able to demonstrate that, would you count that as being influential? And they might say something like this, well, because now you put a number in their head. And you got to be careful when you put numbers in people's heads, because they anchor to it. And they might say, because they weren't thinking of a number. They were just thinking they wanted some improvement, but you just put a number there, and you thought, well, 5%. 5%'s okay, I guess, but, I was thinking more like 8%. And this is when you have to, nail them down. You go, how about this? We'll set 5% as a target, 8% as a stretch target. Is that okay? And all of a sudden, it's kind of like, oh, boy, 5%, 8%. They're probably going to start banking on the 8%, but that's okay. You got to get them to stick to the target, meaning if I can deliver on the targets, I'm influential by our agreed upon definition. That way you get rid of all the vagueness, and now you have something that you can set as targets for your program. And the other thing too is before you do this is my other recommendation. Before you do this, have a pretty good sense of the opportunities that are available in your program. You might want to be able to take a look at some data before you get to that point with folks. But I think sometimes, particularly when you're early on, it may be something as simple as, look, you did 100 robotics assisted surgeries last year. I think we can get a 50% improvement in that. Well, if you're new to the staff and you're just starting, you're thinking, man, I'm going to bring at least 50 cases. So that's 150 cases. That's the 50% improvement. That's a good place to start because that's something you can hang your hat at, something you directly can influence. And so these are kinds of things, these are ways to negotiate with administration and being very specific and very realistic too. The other thing you have to remember is they value operational efficiency, fiscal stewardship, and growth. And we live in a transactional-based economy now in healthcare. We're moving more and more towards value-based care, but right now we're still in the transactional base, which is you do a procedure, you get paid for it. Hospitals do it, but they bill as a DRG, and then they get paid for the DRG. Physicians, surgeons say bill for the CPT code, and they get paid for that CPT code. So everybody's looking at growth, saying that's how I make more money. And sometimes it just simply is, growth is that's how I cover our costs, because sometimes that's just where hospitals are at. In fact, actually, almost half of the hospitals in the United States right now are at that. They're just trying to figure out how to cover their costs. So that's extremely important to them. Administration is charged with the stewardship of the hospital. They have to deliver on that. Now, it's great if you can get good outcomes. It's great if you can get decreased readmission rates and all of that stuff and decreased mortality. They love that. But you know what they love even more? They love getting operational efficiency, meaning they want to be able to generate more revenue at a lower cost to generate more margin. Why? Because more margin allows them to do more things with your hospital. And you may not agree with that, or you may think that that's just not something that you necessarily buy into. But guess what? That's how hospitals run. They have to make a margin. Even non-for-profits have to make a margin. And I think that's something a lot of people don't understand, and that in order to grow, in order to incentivize your employees, in order to provide merit increases, in order to provide just cost of living increases, you have to make a margin to keep up with that. And so you always have to make a little bit more than what you're paying out in expenses, because that allows you to do those things. And it's difficult to maintain a competitive edge when you don't have any margin. So they're always going to be looking at that margin as a way to be able to do those things. Like I said, even non-for-profits, they have to do that as well. So keep that in the back of your mind. That's their job. They're going to expect you to be in charge of taking care of the quality side of it. They're going to want to make sure you do that. But they're also going to have expectations that you're aligning program goals with the things that they value as well. And I also will assume you understand administration speak. And a lot of times when you see these positions, particularly chief medical officer positions or medical director positions, a lot of times you'll see one of the things that they preferred part of the hiring portion of it, which is we'd like to see somebody who has like an MBA or a Master's of Health Administration or something like that. And the reason is that they just want to know that you somewhat understand that language that they speak on a regular basis. And there's nothing more frustrating than seeing a group of administrators and a group of physicians sitting down and realizing that they're talking, they're saying a lot of things, they're agreeing to a lot of things, but I don't think they understand what each other is saying. And I've had that situation. As a chief medical officer, you frequently have your boot in each camp. You have one in the administration camp and one in the medical staff camp. And you have to, what I found was you have to interpret a lot of the language going back and forth. So administration speak is just something that you're going to have to come up to speed on. And it's not that difficult. It's just being in the right place. And a lot of times what I found was helpful for me was clarification. You just say, when stop somebody when they say something, say, I just need to make a clarifying statement here. Let me repeat back what I think I heard. And what I heard was, and if they go, oh yeah, that's exactly what I meant, then you're on the same page. If they say, no, you misinterpreted. What I was trying to say is, and it's important to do that. And sometimes it's almost embarrassing because you have to show that you didn't understand what they were saying, or at least you have to show that you were not completely sure of exactly what they were saying, and therefore that's why you're asking for clarification. And I think that's the part that becomes very difficult for physicians to do, because we're sort of trained to be the one who always has the answer. And now we're thrown into this environment where we don't always have the answer, and sometimes we don't understand what's being said in the conversations. It looks a little awkward at times when you say that, but get over it. The sooner you learn the language, the better you're going to be, more effective you're going to be, that's for sure. And not only that, but over time, people will begin to understand, hey, he really does, or she really does speak the language. I can talk to them. And so they're more likely to call you in and say, hey, I want to talk to you about something. Can you help us with this? Or we're looking at this and we want your opinion on it. Can you give some input on this? it'll do more for your leadership over time than you could ever imagine. So learn the language. So nursing, I put conflict resolution up there as number one because no matter what I say here, it always seems that there's gonna be conflict, even though as tight as the relationship is between physicians and nursing. That's usually one of the touch points of conflict, and it's not uncommon. It breaks my heart to say this as a surgeon, to say it tends to be a surgeon, tends to be a nurse, and so you'll find that happen a lot of times. Sometimes it's just physicians and physicians, and you have to get involved there as well. But what they're going to expect of you is that you resolve the conflict. If there's an issue out there, if a physician treated a nurse poorly, they're at least going to want you to get involved. Sometimes these things escalate to the point that it involves peer review or involves the chief of staff or the chief medical officer. And there are times when that has to be handled at that level. But most of these conflicts are usually, sometimes they're interpersonal, sometimes they're just misstatements or misunderstandings between two people, and you have to go in there and resolve it, or at least get involved in it. And the reason is because it's your program. They're going to expect you to be involved in conflict resolution. And the reason you're going to want to be involved in conflict resolution, when I first started out, I thought, well, no, so-and-so will take care of it. No, that's kind of their job. Let the department chair manage this one. I'm like, no way. If it's my program, I want to know about it. Because if it's something that's happening within the program, I need to know about it. If it's just happening with one person, that's great. That's one thing. But if it's involving a lot of people, and this is like a real source of issue for a lot of people, you got to get in there and take care of it. Not only that, but once you take, first off, all eyes are on you. They're waiting for you to do this. And if you don't do it, they're going to say, wow, he doesn't get involved in stuff like this. And they're going to stop bringing problems to you. And when they stop bringing problems to you, guess what? That's when you stop being useful to the program. So be involved in conflict resolution. It's just so important. But it's going to be all of these stakeholder groups are going to expect you to get involved in conflict resolution. But it's going to be the nursing folks who want you to do that more often than others. Remember, they value patient care, the relationships with physicians, and sensitivity. We talked about that before, but it's such an important piece for them. The other thing you have to remember is that they're almost always employees. They will need to support administrative objectives. That's part of their job. It's just one of those things. They are a big part of every hospital's budget. The FTE, or what they call salaries, wages, and benefits, are the number one expense in hospitals. And nurses are that number one expense of the number one expense. And so they're constantly fighting with budgets and trying to find ways to reschedule and do things. And, it's enormous amount of responsibility that's put on our nursing administrator and our directors and our managers and the frontline nurses frequently. So you have to remember that a lot of times they have that. And if you're a private practice physician and you're just coming in there, when you have cases, there's a tendency to not think about that stuff. You have to think about it. You have to realize that they do that. It's not a knock against them. You just have to remember that that's going to be one of their priorities as well. And then also remember that how nursing management is incentivized. When you're developing your program's goals, always make sure you have somebody from nursing. You better have somebody from nursing on that committee. And the reason is because anytime you can align your program goals with their goals, it increases the likelihood of success. So if you have administration on your committee and you can align goals with them, it's going to increase your likelihood of success. If you have physicians on your committee and you can align goals with them, increases your likelihood of success. And nursing is no exception to this. And we ran into this at one of our facilities. And what we found was that the room where the robot was placed had this extraordinarily high utilization problem. And what they were running into, first off, they said they needed another robot. And we were like, it's not a robot. You don't need another robot. You just need to utilize your room better. And there was months where upwards of 80% of the time in the room with the robot was for non-robotic cases. And the issue was people weren't getting access to the room, and therefore they were having to take their cases elsewhere. And so what we didn't realize was that we in the program, the system oversight, was wanting people to increase their throughput and their utilization in their OR and maximizing the number of cases that they're getting on a robot. What we didn't know and didn't really think about was a lot of peri-op directors were being incentivized to optimize the total OR budget, and therefore it really didn't matter if they had to give up some robotic room OR time to fill it with something else in order to maximize their efficiency from a total OR perspective. that was going to conflict with ours. It just didn't dawn on me until we actually saw it happening in front of us. And had to work around that, had to realize that, okay, we understand how that's becoming an issue, but remember, we have to also make sure that we can optimize the number of cases that are getting on these robots. So it was kind of an interesting problem to have, but you have to keep in your mind on this idea of aligning incentives, because if you don't, you can find that your incentive might actually be a disincentive for them and vice versa, and that usually creates problems for both groups, and both groups end up getting upset about it, and they're not real happy with it, and then next thing you know, it's like your program's starting to tank, and you can't understand why you can't get people on board and engage. Align your incentives. You'll see engagement pretty quick with that. Your community, my recommendation is work closely with your public relations and marketing programs at your hospital. Remember that they're going to want they want a voice of the program. What happens a lot of times is the media will contact them and something will come out. There'll be some article in New York Times or something like that, and they'll say something about robotics, and all of a sudden they want to talk to somebody, and they call at 9 o'clock in the morning, and the folks from public relations are running around trying to find somebody, because they said they're going to send it. They said, yeah, we got people who do robotics here, and then they start running around looking for somebody who can represent them. And they might say the news is going to be here with cameras at 11 for filming. They want to get this on the 5 o'clock news today, because that news cycle is something they have an enormous amount of pressure. So they're just responding to their incentives, and they're trying to get their jobs done too. So they're going to need a face for the program. And so this is my recommendation. Become that face. Become that person. If you don't like it, get used to it. And if you can't, this is my second recommendation. Find somebody who can. Find somebody who's comfortable being in front of the camera. Find somebody who knows your program well enough. There's a tendency, what I've noticed is some places will take their busiest surgeon and the one who loves being in front of the camera the most. And that's not a bad place to start. But remember, the problem is that busiest surgeon isn't the program director. They may actually be pitching more of their specialty rather than the program's contribution to the community. You just have to be aware of that, and make sure that the program gets represented to the community, not just one specialty niche, because that can create problems with the other specialties who feel like they're being slighted. So, you remember, you're going to have to manage all these guys, and what happens is if one of them gets a leg up in the other ones, then they start getting mad and thinking that you're playing favorites, and you can't do that. So that's why it's just best. Be the program director, step up. I say just go out and develop your own little elevator speech, a 2-minute spiel about why your program's good, why you're doing it, the things you're doing. If you have any numbers by then, if you think targets and goals that you've been able to improve efficiency by 20%, we decreased complications by 25% last year alone, and those types of things are always good to throw in the middle of these things. Remember, the community wants a great experience. I mean, patients are coming in. Yes, they want good outcomes, but you know what? Guess what? They think that's the minimal threshold. They think great outcomes, low mortality, no mortality. They think that's the expectation. What they're expecting above that is a great experience. And whenever they get a great experience, guess what? They echo it throughout the community. And you can turn somebody from sort of like your worst enemy into your best friend just by a great experience. And what I mean by that is, I'll give you an example. I had a friend, and her husband had undergone surgery for head and neck cancer, subsequently had chemo radiation, and he ended up having TORS, so transoral robotic surgery. And this was at a time when it was just starting out. And I was a little, when she told me about this, I was like, I didn't read anything. I didn't know anything about it. And so I didn't know what to say. And so, but she went on and told everybody about how wonderful the physician was, how incredible the staff was, how happy they were that they had access to this technology. She couldn't stop talking, so highly of the robotics program at this particular hospital. And it was just amazing to watch that happen. And I saw her sometime later, and she was still talking about it. I can't tell you how many hundreds of people she told that story to. But that's how it happens, And you have to remember that it's always nice to be able to have those type of experiences for patients, because they'll echo it. And the other thing is they want is convenience and access. They don't want to have to drive across town to get an operation. If they can have it in their local facility, and if you're offering a program there that provides it, that's always nice for them. And they will echo that as well. Guess what? We didn't have to go down to the big hospital downtown. We just stayed here locally, and we were able to do it. They also expect good physicians and nurses. They just come with, that's just a minimum expectation. They want healthy outcomes, and we talked about that before, but patients do. They sort of expect that they're going to be okay, that they're not going to have complications, that they're not going to die, that they're not going to spend a lot of time being disabled by whatever operation they get. They expect healthy outcomes. And so they really have this belief that cutting edge technology and practices is what delivers that. Now, we all know that that's not always true. Sometimes it is, many times it can be, but it's not always true. And so they expect that, though, that whoever you are, wherever you're at, that if you're having a robotics program, they consider that cutting edge technology, and the practices go along with it. And so that's something that they're looking forward to. A lot of people are wondering, well, do they really trust robotics? It's like they interpret it a lot different than we do within healthcare. Like I said, physicians were all sitting there going, show us the evidence. I want to see a study. I want to, patients are different. They look at it and go, hey, if you've got it and it looks like it's cutting edge and it can deliver as good, if not better outcomes, I'm all for it. So just remember, it's an expectation, and you have to be ready for that and be able to work with your community to shape that expectation. Your committee, oh my God. Most challenging of your stakeholders. Why? Because they're all in the room at the same time. So these are everybody who has all these competing agendas and competing expectations, and they're all looking at you. They want you to balance it out. And so how do you do that? I think probably the best thing to do is find an area of common interest. I always start with data. The reason is because it's objective. Nobody can really argue with it. A lot of people say, I don't know if I like the quality of it, or I expect better data or more data or something. But as a general rule, it gets you away from looking at a specialty or looking at an operation or looking at a particular group or something like that, where you might be somebody might be complaining about favoritism or something. This way, it's really nice. You just start with data and say, we're going to look at our data. And if you can, try to get it risk adjusted and benchmarked. And we're going to look for the opportunity in our program. Is everybody okay with that? And if you set the rules for how you're going to look at data, interpret it, and then act on it, meaning how are you going to set your priorities for your program, people are usually generally pretty good with that. They may come in with their own agenda, but as long as you start with that, it's usually something people are willing to do. And then once you go down that path, now you're just following the path of the greatest opportunity, rather than sort of like well, I want this. Somebody over there feels like they're powerful enough to make demands of the program. That's great for their individual practice, maybe, but not necessarily what's good for the program. So as a leader in the program, you have to really keep that in the back of your mind. You need to be looking out for your program, not somebody else's self-interest. And so there are going to be times when you have to balance that out, but this is a nice way to do it. The other thing to remember is as the program grows, the priorities of the program will change. And you'll see this when I talk about in performance improvement. We talk about data, but the data will change. Your data needs will change because the program's going to grow, and you're going to have more data, and volume will be there, and all of a sudden you'll be able to look at utilization and cost and quality. And if you're fortunate enough to have a vendor who can track patient outcomes and patient satisfaction with your robotics program, you can now get information on your patients. If you survey your own physicians, you can now start getting information on how they feel about the robotics program and things that they'd like to see change. There's a lot of really cool things you can do. But when you're first starting out, you can't do it all at the same time. And you certainly can't do it all at your first meeting, which is there's a tendency to want to do that. Pick a few things and then start there. But as your program grows, things change. And what I've gotten here is, and the people will change as well. And that's just an expectation. What's going to happen is that over time, people are going to come and go. They're going to get offered jobs somewhere else. Family's going to want to move for different reasons, or people are going to retire, and you have to be prepared for it. And so, what are you going to do when that happens? Well, succession planning. The definition I put in here is just right out of Wikipedia, but I condense it down a little bit. But it's basically a process for identifying and developing people with the potential to fill key positions in the program. It's not to be confused with replacement planning. Remember, replacement planning is, hey, like we used to, I still see this in the operating room. You're in the middle of a case, and your circulating nurse all of a sudden has to, leave for some reason, and somebody comes in, and you turn to the news person, you tell them that you need something, and they look at you and go, "Where's that?" They've never worked that room before. You're like going, "That's replacement planning, right?" Now you're like, oh, great. The person with all the experience just left, and now you're back. Now you're stuck with the backup, and not a fun place to be when you're in the middle of an operation. So Succession planning is more about grooming, developing people, identifying first off who the people are. We talked about this early in the program and the infrastructure. Identify who those people are and start thinking about who would take their position if they were no longer here, and how would we develop them. If you have an administrative assistant and they're gonna retire at the end of the year, what you want to be able to do is say who's going to take this person's place, and then how do we get this person in there and give them enough experience with our program so that when day one hits and that other person isn't here, they can hit the ground running and our program won't even feel the effects of any changes. That's the way you want to do it. Unfortunately, I didn't always do that. In fact, in some places I did a pretty good job of it, in other places I didn't, and I always regretted it when I left, because as soon as you leave and you see the program starts to suffer and you realize, oh, succession planning, I didn't do a good job of that, or I didn't plan for that one. So when do you start planning succession? On day one. You really do. That's the way to do it. Start thinking about who's going to take my position and how am I going to groom them and develop them for that. So that's the thing you have to do, is one, identifying somebody and then developing them. If you do one and you don't do the other, then you just identified somebody who's going to have a struggle when they first take over on the program. So here's just some objectives. Your succession planning. One, identify who's going to own the process of succession planning. So in a lot of hospitals, typically succession planning, at least for administrative leadership, is done through HR or talent management, which is usually just a branch of HR, human resources. And so they develop people. They identify people for leadership. They see who's the rising stars and how do we get them ready for the next step in their career. We have to do the same thing. Physicians are not always really good at that. I think we do a pretty reasonable job in medical staff. I mean, some are better at it than others. They bring people up through the committee structures and get them involved in projects, and then get them into leadership positions, and eventually get them to the point where they can now manage the entire medical staff. And we have to do the same thing for our programs. We have to find the people and then fill those positions. But remember, as a lead, whether it's nursing or physician lead for your robotics program or administrative lead, you're going to have to identify all the key roles, not just the physicians. And you're going to have to identify the competencies of the program. And hopefully through this program, you started to see who the people are that are going to be there and what they're going to do, and what you should be looking for in the person who's going to succeed them, because that's going to be important. So once you identify your potential candidates, another one I learned the hard way, coordinate your selection with management. I was on a committee one time and really didn't know a whole lot about what was happening outside of that committee for this particular area. And we had somebody who I thought was going to be a great candidate for grooming, and mentioned it to our chief nursing officer, and she looked at me and said, that person's going through our corrective action process right now. Not a good time to be promoting someone. And I said, oh, okay, I didn't know that. Well, they don't tell you. That isn't common knowledge, but I didn't know that. So what I learned from that is that when you're in that position, you're going to start looking at people who you want to develop for your program. Go to the management. Just start asking about them and say, hey, how's this person looking in other places? And is this someone that is okay for us to identify and then develop for our robotics program? It'll save you a lot of heartache down the road. I never made that mistake again, but boy, I'll tell you, it's kind of embarrassing when you do it the first time. So try to avoid that. Provide critical developmental experiences for candidates. So say you're going to bring in another physician, you want to develop them as a potential lead for your robotics program. Bring them in, have them be part of it. Put them in charge of a few projects. If you're going to be late one day and you say, hey, can you start the meeting for me? Let them run the meeting for the first 15 minutes. Let them see what it feels like to run that meeting. And then walk in and then kind of watch them sort of continue to run it, and then slowly take it over, and then give them feedback. Sit down and say, hey, this is what I saw. Hey, when so-and-so just started carrying it on, do you realize, we only allotted 5 minutes for that discussion, and they carried on for 15 minutes. You let them take up that whole time with that. You have to learn how to cut them off and kind of direct them so that if we need that much time, we can always schedule that down the road. But you can't consume this meeting when other people are ready to either present or to hear other agenda items. And so you're robbing from other people. So that's how you develop them. You have to be able to point out, why it's important for them to step in and set some boundaries with folks in the committee. Pick a succession date and communicate this to all stakeholders. There's nothing more, nothing worse that you can do is to pick a successor and have a date when they're going to turn over, but you never communicate it to anybody. And now what happens is, the new person shows up and it's like, what are you doing here? You're running this committee? Why? When did that get decided? You have to communicate to people. You have to, and it's always good to, I think it's just good to, telegraph to the groups, your stakeholders, who you're thinking about, who's going to take over. Because sometimes they may have some input in that and want to be able to say, well, maybe that's a good idea or not a good idea. So it gives you some time, and it gives them time to adjust. And then when you announce a date and say this is when this person's going to take over, it's smooth sailing. They just step in the position, and everybody's already bought into the idea that they're the new leader. And so it's important to be able to do that. If you don't do that, you can create a lot of problems in your stakeholder groups. So as before, if you have any questions, feel free to contact me, Terry Loftus, MD at gmail.com, or visit www.loftushealth.com.